Hello, my name is Virginia Shaffer. I'm excited to talk to you today about the role of MIS in the management of pneumoperitoneum. I have no disclosures. I'm sure many of you have been faced with a radiologic finding such as this. Clear, free air. Well, it's one of the few things that is not good when it's free. This is a common algorithm in dealing with pneumoperitoneum. Emergency laparotomy is here in the algorithm. Our challenge for this talk is to place MIS in this place. Can laparoscopy be used instead? There are several causes of pneumoperitoneum, from perforation of a hollow viscous organ, pneumatosis coli, post-surgery, peritoneal dialysis, among others. One of the most common causes is perforation. Among perforations, diverticulitis can be a common culprit. For the purposes of this talk, I'm focusing on the use of MIS in diverticulitis with peritonitis and mostly Hinchey 4. Let's begin. What is the best treatment? Well, it depends on what year it is and who you ask. If it's 1907 and you ask Dr. Mayo, then the answer is a 3-stage operation. The 3-stage procedure was common practice for treating diverticular disease. The first report was by Mayo in 1907. The classic 3-stage operation is number 1, diverting colostomy and drainage, number 2, resection of involved colon and anastomosis, and number 3, closure of the colostomy. In 1924, the Mayo Clinic presented its results and felt it was the safest way to proceed for perforated diverticulitis. For the next 20 years, a preliminary transverse colostomy was recommended with resection 3 to 6 months later. The rationale was that the resection in the acute setting was too difficult and could lead to iatrogenic complications and increased morbidity. This was the gold standard treatment for many years. Then controversy increased as the use of antibiotics in colon surgery increased. There were many advocates of the 3-stage procedure, but reports began to surface of better results with 2 stages. The controversy remained because the only evidence was expert opinion and small case series. Enter the Hartman's procedure. In the 1980s and 1990s, the standard practice shifted from a non-resectional initial operation, a diverting colostomy, to resection of the involved segment of sigmoid. Some surgeons advocated a 2-stage instead of a 3-stage operation. The procedure became popularized as the Hartman's procedure. Number 1, resection of the diseased segment of colon with construction of a proximal colostomy and suture closure of the distal rectal stump. The second stage was the colostomy closure and restoration of GI continuity. Studies were published in favor of the 3-stage procedure, and studies were also published in favor of the 2-stage procedure. Controversy remained, but in 2000, ASCRS published practice guidelines that the 3-stage approach was no longer recommended for most patients because of the high associated morbidity and mortality. Let's step back for a moment. Who was Hartman? Dr. Henri Hartman was a prominent and well-respected staff surgeon in Paris who popularized the Hartman's procedure. Well, what is the Hartman's procedure? The Hartman's procedure was originally described as a procedure to remove an actively bleeding or obstructing carcinoma of the upper rectum transabdominally. The rectal stump was closed and the end sigmoid colostomy was fashioned. Dr. Hartman described his procedure in 1923 as an alternative operation for cancer and felt it was designed as a final operation. There was no intent to reestablish GI continuity. The way a Hartman's procedure was originally described, it was an alternative method of treating an obstructing or bleeding cancer with no plans of restoring GI continuity. While many patients to this day do not undergo the restoration of GI continuity and remain with permanent stomas. Maggard et al. In 2004 found that out of 1,176 patients who underwent a Hartman's procedure, only 65% had undergone reversal at 4-year follow-up. Vermeulen et al. In 2009 found that of 158 patients who had undergone Hartman's procedure, only 45% were reversed. Of 19 who had undergone primary resection and anastomosis with diverting loop ileostomy, 74% were reversed. They also found post-Hartman's procedure reversal morbidity was 44%. Restoration of GI continuity can be technically challenging and is associated with significant morbidity and mortality. Aiden et al. In 2005 examined 121 patients who underwent Hartman's reversal, and the surgical complication rate was 43.8%. Is laparoscopy an answer? Some advocates of laparoscopy advocate the use of laparoscopy not only for the resection of the diseased segment of colon, but also for the primary anastomosis, with or without a protected loop ileostomy. There are non-randomized studies that support primary anastomosis in comparison to Hartman's procedure, with primary anastomosis not associated with worse morbidity and mortality. Some studies show improved morbidity and mortality with primary anastomosis. ASCRS revised their guidelines in 2014 to include primary anastomosis with or without loop ileostomy as an option in perforated diverticulitis. For the purposes of this talk, I'm focusing on the use of laparoscopy in perforated diverticulitis as it pertains to the use of laparoscopic Hartmans. These initial studies are proof of concept and feasibility without harm. The first study had 66 patients undergoing emergency surgery for perforated diverticulitis. They had median OR time of 110 minutes and median length of stay of 5 days, only one conversion to open. Agraba and al. Published their case series of 7 patients with no conversions, and they were all reversed in 2 to 3 months. Chouillard and al. Published their laparoscopic series of 31 patients, and again, 90% reversed and had comparable morbidity. Soroki performed a review of 4 trials with a total of 181 laparoscopic cases and 255 open ones. They found the laparoscopic group had lower post-op complications and length of stay, but no difference in OR time, reoperation, and 30-day mortality. Now, one of the criticisms is that we are not comparing the same types of patients, that likely the patients who are not as sick are getting laparoscopy and the sicker ones are getting open surgery. Propensity score matching is a statistical technique for dealing with confounding bias in observational studies. The next 2 studies use propensity score matching to try to answer this question of whether laparoscopy is an answer in perforated diverticulitis. One study is from the centers in the Netherlands, and one is from US data. Turley and al. Used the American College of Surgeons National Surgical Quality Improvement Project, which includes data from all over the US. They found 1,116 open cases to compare with 70 laparoscopic cases. They found decreased overall complications, decreased prolonged ventilation, and decreased length of stay. When propensity matched, they had 67 open and 67 laparoscopic cases. They found no difference in the outcomes. Phoenix et al. Used data from 28 Dutch hospitals. They propensity matched 2-to-1, 39 laparoscopic cases with 78 open cases. They found decreased length of stay, decreased post-op complications, and decreased stoma rate at 12 months in the laparoscopic group. These are two studies with two results. But as you can remember, best practices change over time and always with controversy. First, there was the open 3 stages, which were the standard of care for perforated diverticulitis. Then open Hartmans. Then controversy over laparoscopic lavage, laparoscopic resection with anastomosis, and laparoscopic Hartmans. It is likely that laparoscopy is yet another step in the evolution of treating perforated diverticulitis. Overall decision for laparoscopy should be based on patient stability and clinical factors such as hemodynamic stability, acidosis, organ failure, among others, and on the experience and comfort of the surgeon with laparoscopy. Several European surgical associations wrote a consensus statement agreeing with such. So the next time you have a patient with pneumoperitoneum from perforated diverticulitis, I want you to consider the patient's clinical situation and your comfort with laparoscopy, and consider utilizing laparoscopy based on this information. Thank you very much.